So today we have with us Anupama ma'am from Physiology. So you have two teachers for two topics to be done today. Let's start with this, and we'll start with Prolactin ma'am first.
All right.
Okay,
So
you can start with the Physiology section over there, then I'll pick up the medicine part of Prolactin.
Right. All right. So good evening and welcome to this integrated session. And the best way, as I keep insisting, the best way to learn is start with physiology and then go on to medicine. So we'll start with prolactin, two important hormones of the anterior pituitary that we're going to be doing today, and that is growth hormone and prolactin. Now, the first important point, which is from an examination point of view, the hormones, both prolactin and growth hormone, these are water-soluble hormones. If you remember, the hormones can be divided into lipid-soluble and water-soluble hormones, and these are the typical lipid-soluble hormones are your steroids and thyroid. Thyroid is also a lipid-soluble hormone. The peptide hormones are water-soluble. So growth hormone, prolactin, these are both water-soluble hormones. And all water-soluble hormones need second messengers, except these four hormones which do not need second messengers, and that is growth hormone, IGF-1, prolactin, and insulin. And the important point is that growth hormone, IGF-1, prolactin, these do not need second messengers because they act via the JAK-STAT pathway. They act via the JAK-STAT pathway. And what about insulin? Insulin does not need a second messenger. This is because the insulin receptor itself has tyrosine kinase activity. So these are the reasons, or these are the four hormones, which water-soluble hormones, which do not need second messengers. And why they do not need second messengers, I've already elaborated here. Growth hormone, IGF-1, prolactin, acting via the JAK-STAT pathway, and insulin receptor itself has got tyrosine kinase activity. Now, when we look at the anterior pituitary has got the cells in the anterior pituitary can be divided into acidophils and basophils. Now, both the acidophilic cells are the growth hormone secreting cells and prolactin secreting cells, isn't it? Now, so many times you hear of an acidophilic tumor of the pituitary, isn't it? So the acidophilic cells are the growth hormone secreting cells, that is somatotropes, and the prolactin secreting cells, that is lactotropes. Now, when I look at what are the important point about prolactin is, now prolactin is normally kept, the prolactin levels are very, very low. This is because prolactin is controlled by, or prolactin levels are, prolactin is under the control of an inhibiting factor from the hypothalamus, and that is the prolactin inhibiting factor. Prolactin inhibiting factor decreases the secretion of prolactin from the anterior pituitary. And what is prolactin inhibiting factor? This is nothing but dopamine, right? So prolactin inhibiting factor from the hypothalamus will keep the prolactin levels very, very low. But there are certain situations in which the prolactin levels will rise. And for that, I have this little mnemonic for you, new pets shock. These are the conditions which will cause an increase in prolactin. New stands for nursing. Nursing is when the mother is feeding the baby. Every time the mother feeds the baby, the suckling produces an increase in prolactin levels. Pregnancy, there is a steady increase in prolactin. Estrogen causes an increase in prolactin. T is TRH. TRH will increase in hypothyroidism. This will cause an increase in prolactin, right? S, stress, strenuous exercise. Strenuous exercise. Sleep. Stages 3 and 4 of NREM sleep. NREM stages 3 and 4. This is when prolactin levels will increase. Prolactin levels increase in the first half of sleep. Both growth hormone and prolactin levels increase in the first half of sleep. Sexual intercourse. Sexual intercourse, breast stimulation. These are the conditions which will cause an increase in prolactin. H stands for hypothyroidism. Hypothyroidism causes increase in TRH, and TRH will increase the prolactin levels. Now, a very common presentation in hypothyroidism is galactorrhea. So if you have a non-pregnant woman presenting with galactorrhea, it is important to rule out hypothyroidism. Yes, before we think of a prolactinoma, think of hypothyroidism. Rule that out. So H is hypothyroidism, O is opiates, and P phenothiazines. So this is your new pets shop. Phenothiazines, new pets shop. These are the stimuli which increase prolactin secretion. Now, we need to look at what is going to happen to the secretion of hormones during pregnancy. So this is an interesting graph which shows you what happens to the level of different hormones during pregnancy. On the x-axis, we've got weeks of pregnancy. So we see that the HCG levels will rise in the first trimester of pregnancy, and then as the placenta develops, there is a steady increase in estrogen, progesterone, and prolactin. This is prolactin. Prolactin levels will steadily rise during pregnancy. Steadily rise during pregnancy. Now, as soon as delivery happens, estrogen, progesterone, prolactin, they will show a sharp fall. Estrogen and progesterone will show a very sharp fall. Prolactin levels will also increase. The decrease in prolactin will take 2 to 3 weeks. But the important point that you have to understand is that every time the mother feeds the baby, there is going to be an increase in prolactin levels. Prolactin levels will increase at the time of feeding, right? But not in the intervals between feeding, right? So let's say this once again. There is a steady increase in prolactin levels during pregnancy. After delivery, there will be a fall in the basal level of prolactin secretion. This takes about 2 to 3 weeks. Maximum fall occurs in the first week. By about 2 to 3 weeks, the basal levels of prolactin will reach the pre-pregnant levels. But every time the mother feeds the baby, there is going to be an increase in prolactin secretion, and not in the intervals between feeding. Now, what is the action of prolactin? Now, before we talk about the action, the important thing to understand is that suckling, which is a physical stimulus, causes the release of both prolactin and oxytocin from the pituitary. Prolactin from the anterior pituitary, oxytocin from the posterior pituitary. And the secretion of both these hormones is by a positive feedback mechanism, right? Positive feedback mechanism. Now, the difference between prolactin and oxytocin. Now, prolactin will increase the milk, the synthesis of milk proteins, and thereby increase the milk secretion. And oxytocin causes what is known as the milk let-down reflex. Milk let-down reflex. Oxytocin causes contraction of the mild epithelial cells which surround the ducts and thereby causes the milk let-down. The next important point about prolactin is that prolactin will only act on the breast which has been primed by estrogen and progesterone. So during pregnancy, the breasts are primed by estrogen and progesterone, and prolactin will cause an increase in milk secretion only after the breasts have been primed by estrogen and progesterone during pregnancy. Now, prolactin will increase the mRNA levels and subsequently increases the production of 2 important proteins which are present in milk, and that is casein and lactalbumin. This is as far as your prolactin is concerned. The physiological aspect of prolactin. May I request Dr. Achin to take over from here? Or would you like me to complete growth hormone and then, or all right. I think Dr. Achin is ready to discuss the etiology of hyperprolactinemia. All right.
Thanks a lot. Thanks a lot for enlightenment. It's a very, very important topic anytime if you come across with. Prolactin and growth hormone are Karan Arjun. And you should remember that they are from the same mother PIT1 gene. That's a very, very important gene that only not codes for this Karan Arjun, but another thyrotroph also. Right. So let's start with this now. The etiology of hyperprolactinemia, right? Now, if I look at the etiology of hyperprolactinemia at this moment, we've got various causes for this. The first one happens to be the physiological cause. The physiological, as you understand, that happens naturally with the circumstances in life, in which we find the pregnancy being the first and the foremost one, as the thing is known that the estrogen is something which has got a hyperplastic effect on the lactotroph cells, so it's going to basically increase the whole thing, right? Now the second thing that we have is the lactation thing. Nipple stimulation again is a very important potent stimulator, not only for the oxytocin but also for the prolactin, as we know. Third happens to be the sleep part, and most of you like to sleep, and that's the best hobby. I also have got to sleep. I always follow my hobby every day. I've got a passion to follow my hobby. Now, can you tell my question to my this answer to my question that in which phase of sleep will we find the highest prolactin level? In which phase are we going to find it in the highest amount? Will it be the REM or will it be the non-REM sleep? So please answer in the chat box. Okay, I believe you're not sleeping. Good. It's the NREM stage, especially the stage 3 and 4. I'm very happy that you guys know the stages also. Yeah, I think so. You're also following your best hobby. So who wins is the NREM sleep over here. And that's a clarity on this concept, right? Good. Further on, a very important thing that we find is a stress factor, which is basically going to increase the whole prolactin. So stress is again something which is physiological, I believe, not pathological for you. Apart from this, the chest wall stimulation that can be due to trauma, surgery, or more often due to some virus like herpes zoster virus. If there's a herpetic lesion all across the chest, that will continuously raise the prolactin in the patient. Systemic disorders, yes, we have got the list as chronic kidney disease because the basic excretion of prolactin happens from the needle tissue. In CKD is not working properly, so we have got retention and a higher level. Hypothyroidism is another factor that we know that TRH not only stimulates the thyrotroph, but it also stimulates the lactotroph, right? Then we have, oh, sorry, I again wrote the stress on the systemic disorder. Now, I should have not written stress over here. Maybe I could have written something else. Can you correct me on this? What else should I have written over here? I'll correct it here itself. Seizure disorder, right? So seizure disorder is another disorder that we find as a systemic disorder, which we find in the patient would increase the prolactin. Post-ictal true seizure, most important, right? Then we have the stalk damage, something that we find as a stalk, which is basically transporting the dopamine to the lactotroph cells through that tubulo-infundibular pathway has been damaged. Maybe due to tumors, for example, craniopharyngioma, trauma, that is head injury, as we know. Pituitary hypersecretion, then this important thing again. In the pituitary hypersecretion, we may see this whole thing due to a prolactinoma, a tumor that I'm going to discuss just now. Then we have the drug induced, yes, dopaminergic antagonist that we know, that is the typical antipsychotic. Now, can you tell me an atypical antipsychotic which is associated with hyperprolactinemia as a problem? Waiting for your answers, and you can just type the first initials of that drug. I'll be happy with that. So the drug which is atypical antipsychotic but has been associated with hyperprolactinemia. Now that's not only a medicine, it's a psychiatry and a pharmac question also. So that's the risperidone. Good, you guys know that. Then we have the dopamine depleters like methyl dopa, tetrabenazine. opiates also is in the list in Harrison, and H2 antagonists like ranitidine and cimetidine as well, right? Okay. SSRI is also in the list for hyperprolactinemia drugs. And then we have a calcium channel blocker in the list over here. That's the verapamil, right? Okay. So let's quickly refresh our memory on prolactinoma. First of all, we know this fact that it's the most common pituitary adenoma, which is functional, right? Now, how do we divide it? If it is less than 10 mm, I call this as a microadenoma. If at all I find it to be more than 10 mm, it will be macroadenoma. And microadenoma is something which is more frequent in female than the males in a ratio taken as 20:1. More than 10 mm is known as a macroadenoma, and the ratio here is equal. In female to male, it's equal 1:1, right? 90% of the tumors, pituitary adenomas, or even prolactinoma happen to be the microadenomas that we know. And just 10% are the macroadenomas that we have. The average age of onset that we take over here is taken as between 25 to 45 years of age, right, for prolactinoma patients. Now just see the quick review on the systemic symptoms that we find in males and females. In females, we have got galactorrhea. Can someone of you tell me galactorrhea means excess of milk production in the breast tissue beyond how much time of childbirth? Should I take it as 1 year, 9 months, or 6 months? Any ideas on this? Galactorrhea is defined as excessive milk production after how many months of childbirth? Is it 1 year, 12 months? Yeah, 6 months. That's the correct definition as per Harrison. Good, you guys know that. Amenorrhea also classically happens. That's why it's amenorrhea, galactorrhea syndrome, and infertility, right? Now, can you tell me what is the most common presentation in females that we find for this disease? Now, that's again a controversy, I believe, but has been clarified in a lot of endocrine and infertility books as well. It's always taken as infertility. Generally, we take it as infertility as one of the most common presentation of prolactinoma, because sometimes galactorrhea won't happen that much, and it is a hypogonadism that may be a reason for infertility in them. Males, lethargy, reduced libido because of low testosterone, because prolactin has a gonadotrophic effect. It inhibits the GnRH production there. Galactorrhea, that happens quite late in them. Impotency in males is another symptom that we find. Now we have the compressive symptom with us, right? In the compressive symptom that we find with the patient, we have this, the bitemporal heminopia with the patient, right? So we have a kind of a bitemporal heminopia in the patient. Osteopenia and weight gain are the two other symptoms I want to add into the list of these patients, right? Okay. Workup, we all know how to deal with such people. Normal serum prolactin that we have is in the range of 10 to 20 in males, and it's in the range of 10 to 25 in females. Increased serum prolactin, if any time happens, it can be physiological, like pregnancy, lactation, chest wall stimulation, stress that we know, in a range taken as 25 to 40. It can be in the range of 25 to 100 for hypothalamic stalk lesion, and especially the drug-induced iatrogenic. If you find it to be more than 200, possibly we're sitting at a case and a diagnosis of what? Prolactinoma, correct? Now, high prolactin in an asymptomatic patient and a normal prolactin in a symptomatic patient. What are the two differences that we find over here? So why this colavary? I always say this. So I have a patient with me who has got a high prolactin and is asymptomatic, and a normal prolactin in a symptomatic patient. So one end we have, on the other side we have macroprolactinemia, on the other side we have got as a hook effect. What is the difference now? Look at this now. There is aggregation of prolactin via cross-linking by the IgG antibodies. So all the prolactin is basically aggregated by the antibodies of the immunoglobulin G type in the blood, like this. So what happens? We have a large prolactin molecule with a lot of, sorry, switch on the camera. We have a lot of prolactin molecules surrounding a particular antibody, and this large prolactin is bioinactive, right? Who detects this is a polyethylene glycol electrophoresis or maybe a precipitation technique which is going to find it out. So if we have a patient with a high prolactin and asymptomatic, is possibly we are catching a lot of prolactin together because of the antibody aggregation over there. Hook effect is simple. Very high prolactin saturates the reagent antibodies this time. And it happens like this. So we got antibodies which are lesser in amount in the reagent and more prolactin in our blood. So not all the antibodies in the reagent are going to catch it. That is going to result or reflect in a form of a normal prolactin level in the patient, right? But the patient is symptomatic. So how to find it out is very simple. Repeat the test in 1:100 dilution, right? Wash out the excess and just match the antigen with the antibody present in the reagent. So we have two contrast things, a false high prolactin, that is macroprolactinemia, and quite a false normal prolactin that is referred as a hook effect. MRI of the pituitary will help me to find it out in a patient of prolactinoma. So if the size is less than 10 mm, I call this as a microadenoma. If the size is found to be less than 10 mm microadenoma, as I say, we have to start with a dopamine agonist at the earliest. For 1 to 2 months, you have to give the therapy, get the serum prolactin done for them. If it is less than 50, continue the therapy for 2 more years and reassess the patient yearly. And most important, after 2 years, you can comfortably stop the therapy. I've been stressing on this point in the classroom teachings also, that dopamine agonist not only results in a decrease in prolactin level, but also abolishes the tumor to a larger extent. So there won't be any residual tumor beyond 2 years, most likely. If it is more than 50, then we need to operate upon the tumor and by the surgery, which we know as a transsphenoidal resection. Macroadenoma, if the size is more than 10 mm, in that case, I'll start with the dopamine agonist, and then we'll get the MRI done of the pituitary at around 4 months as per the protocol. If the size remains unchanged, we are going to operate by the same surgery. If it has decreased, then continue the dopamine agonist lifelong, right? So at the end of the day, what we find, micro or macro, the treatment of choice happens to be what? Simple, medical. All the time it's medical. Now let's look at the two drugs which I want to compare, bromocriptan and cabergoline, right? Which are the commonly used drugs. Bromocriptan happens to be a short-acting agent. Cabergoline on the other stuff is a long-acting agent. The dose of bromocriptan is taken as 0.625 to 1.25 milligram per day, and for cabergoline is taken as 0.5 to 1 mg twice weekly. Once or twice weekly we can take it. Now, normal gonadal function, how much is the gonadal function becoming normal if you give either of the two drugs? 70% for bromocriptan and 80% for cabergoline. So that's very interesting phenomena, that or the problem, hypogonadism, infertility, whatever is there, is often resolved with cabergoline much better. Decrease in the size of the tumor, if I look for, it's 70% with bromocriptan. It's more than 50% for cabergoline. Most of the time in cabergoline patients, we find that we have got almost a good result in the size decrease as well. When I look at the side effect, I'm more bothered about bromocriptan. Why? It's a dopamine agonist, so it's going to cause what? A lot of these problems like constipation, dry mouth, nausea, insomnia. All these troubles are very common with bromocriptan. Especially constipation and dry mouth happen to be more frequent trouble. Cabergoline has only one trouble, which I saw in the book, that it at a dose at 3 mg, some cardiac or valvular regurgitation phenomena could happen with the patient. So the consensus is quite clear in this, that the drug that we consider better for therapy is a longer acting, less toxic, better result anytime is a cabergoline therapy. Right. Now the situation is like this: if a female with a prolactinoma on dopamine agonist, of course, wants to conceive because she's come with hypogonadism, infertility, and with all these drugs we have treated the patient very well. How are we going to proceed in this? First, allow her to have 3 normal cycles. This is very important thing. Second, discontinue the dopamine agonist, possibly because it can be teratogenic to some extent. So, pregnancy is desired after this. During the assessment in pregnancy, we are going to watch for serum prolactin? No, because prolactin rises physiologically during pregnancy, so it doesn't make sense at all over here. Assessment has to be done on two things. One are the compressive symptom, which I know is headache, and decrease in vision. Anytime if I find this, then I'm going to start with bromocriptan therapy. It's very clear. It's a shorter acting congener, I agree, not that successful as cabergoline, but the teratogenic profile of this drug, as we know previously, has been quite stable one. So it doesn't have much of teratogenicity. Then if there is no response, then in that case, I'm going to go for a transnodal resection. I just forgot to write here, no response is there, then only. So again, we make the consensus very clear over here. Drug of choice for prolactinoma in a non-pregnant female is cabergoline. In a pregnant female becomes bromocriptan. In males, since they cannot conceive, it's cabergoline. Not a teratogenic problem there at all anytime. With visual defects, again, I want to reiterate on this, even with the visual defect, the best line of therapy happens to be the medical one. Hyperprolactinemia, right? Hyperprolactinemia, which you understand as a disorder without prolactinoma. In a fertile female, we're going to go with bromocriptan. Since they're fertile, they can conceive in any cycle, so it's always better to take the course of a drug which has got a better safety record with it. Okay, so this is the consensus for the drug of choice that we have to carry home as a message. Don't do any blunders on this, right? So I've got some questions with me. Can you answer those questions for me? Which of the following is false about prolactin? It's a physio question which I found in Harrison pre-test manual, right? Which of the following is false about prolactin? Can you answer my question on this? Peak prolactin level occurs between 4 to 6 cm. Yes, that's a fact we need to know. Circulating half-life of prolactin is just 50 minutes. That's also correct, no doubt on this. It's a predominant central control mechanism is inhibitory. Yes, dopamine, tubuloinfundibular pathway. And to your surprise, the option that you hated in your life every time, none of the above is a correct answer. So whenever you find all of the above, you're happy. When you find none of the above, you're unhappy. But feel happy on this because none of the above is false. Okay, right. So most of you know the answer correct. I'm happy. So tell me this one now. A 30-year-old female presents with amenorrhea, galactorrhea, infertility. Her serum prolactin is found to be 30 microgram per liter, slightly high. Her MRI shows a pituitary adenoma of 25 mm size. So God, she's symptomatic. She's got a tumor. Her prolactin level isn't that high. It's just 30, slightly high. What is the next line in management? First of all, tell me what are we seeing over here? Are we seeing a macroprolactinemia, or are we seeing this as a hook effect? My question is this for you. You'll find the answer automatically then. What are we seeing over here? Are we seeing the macroprolactinemia over here or a hook effect? Long-term memory is good, but working memory is very poor. Some of you have answered it on macroprolactinemia. Macroprolactinemia is a very high prolactin level with no tumor, no symptom. False high. Hook effect is just the ulta, what you see in this question. So if you see it as a hook effect, don't go for a peg. Repeat her serum prolactin in 1:100 dilution. Then only you'll get to know about it better. Okay. And reassure and follow up and repeat serum prolactin doesn't make any sense at this moment, right? So most of you know the correct answer, majority of you. Good. Now we got another question. A 29-year-old female with a pituitary microadenoma on cabergoline 1 mg per week presents at 12 weeks of gestation. She's already pregnant and she's on cabergoline. She did not know that she was pregnant and she was taking cabergoline by some doctor and all. And she's a case of microadenoma. What should I tell her? What should I tell her now? Read the options again. Advice for a termination of pregnancy as cabergoline was continued in the first trimester. Follow with a prolactin assay monthly, MRI to look for the enlargement of tumor, reassure the patient, evaluate further only if the symptoms like headache and visual disturbances are present. Bolo, what's your correct answer? Good. Quick answers, D. But when the MRI leads already shows adenoma, then why don't we go for medical treatment directly? I believe you're asking for the previous question. Yes, we go for it, but we have to have a justification, no? See, I'll tell you the story behind this. The radiologist on the other end will never write prolactinoma. He will write pituitary adenoma, please correlate clinically. And I was born for this. So it's like 3 words which the radiologist wants to tell, 3 golden words is please correlate clinically. So see, your judgment is correct, that is a case of prolactinoma, but you need to have a high prolactin for that. So it's always better to hook effect and rule out and go further. Okay. Right. So this is the last question I believe you want me to explain, or the previous one you want me to explain. This one or this one? See, this is very correct. Most of you have answered D, and I hope this thing is very correct. Even she's taking cabergoline, nothing wrong will happen. Don't worry. Let her continue. Jo chal raha hai, usse chalne do. That's the best thing. Continue same therapy. And tell her to come back if she has visual symptoms and headache. Then only we're going to do something extra. Okay. Chala. I think so. We're done for this one. Right. Ma'am, over to you.
Yes, thank you. Thank you, Dr. Achin. Let's have a look at the growth hormone secretion. Growth hormone. So, all right. So there we are. Now, I already told you now, like I said, the acidophilic cells of the pituitary secrete growth hormone and prolactin. Now, the anterior pituitary secretion is controlled by hypothalamic hormones. And for growth hormone, there are 2 hormones of the hypothalamus which are involved. All right. Just 1 second, please. All right. So, like I said, growth hormone from the anterior pituitary, this is under the control of hypothalamic. So, the somatotropes of the anterior pituitary secrete growth hormone. This is under the control of secretions from the hypothalamus. Now, hypothalamus secretes GHRH, which will increase the secretion of growth hormone, and hypothalamus also secretes somatostatin. And somatostatin will reduce the growth hormone secretion. Right. So these are the 2 important hypothalamic hormones which affect the growth hormone secretion. But we have to remember that the primary hypothalamic factor controlling growth hormone secretion is GHRH and not somatostatin. Right. So GHRH is the main factor regulating growth hormone secretion. So we have to keep that in mind. Now let us see what are the stimuli which can cause an increase in growth hormone. Now, the first important stimulus which causes increase in growth hormone is hypoglycemia. Anything which decreases the blood sugar level is an important stimulus for growth hormone secretion. Stress. This is an extremely important stress hormone. See, which are the stress hormones? When I talk about the stress hormones, all stress hormones, the common factor about the stress hormones is obviously the stimulus which causes their secretion is stress. And number 2, all stress hormones will increase the blood glucose level and the free fatty acid level. That means basically they increase the energy substrates. To fight stress, you need energy. And the energy substrates are glucose and fatty acids. So all stress hormones will increase the blood glucose level and the free fatty acid level. Now, which are the stress hormones? Stress hormones are catecholamines, glucocorticoids, growth hormone. Growth hormone is also an important stress hormone, growth hormone. Then glucagon. Glucagon is another important stress hormone. ADH. ADH is considered a stress hormone. Thyroid, on the other hand, a lot of people say, I've written a plus minus in front of thyroid. A lot of people say thyroid is increased in stress, and some authors believe no, that is not true. So thyroid is a plus minus. It is, some people believe yes, it is a stress hormone. Others say it is not a stress hormone. So, but the point you have to remember is one of the primary stimuli for the secretion of growth hormone is stress. Exercise, fasting, ghrelin. Now, what about ghrelin? Now, ghrelin is a hormone. It's an orexigenic. Orexigenic means it increases appetite. And this is secreted primarily from the stomach. You also have small amounts of ghrelin secretion from the pancreas, but the major source of ghrelin is the stomach. So ghrelin is a very important growth hormone secretagogue. That means it increases the growth hormone secretion. Certain amino acids such as arginine, leucine, arginine and leucine, they increase the growth hormone secretion. Protein meal, which is rich in arginine, leucine, glucagon by itself also causes growth hormone secretion, increases the growth hormone secretion. Sleep stages, NREM sleep stages 3 and 4, and the sex hormones, estrogen, progesterone, estrogen and androgen, will increase the growth hormone secretion. So this is the list of stimuli which will increase growth hormone secretion. What are the stimuli which will decrease growth hormone secretion? REM sleep. REM sleep causes a decrease in growth hormone secretion. Glucose itself, remember, hypoglycemia increases growth hormone. Growth hormone will in turn increase the blood glucose and the free fatty acid levels, which will have a negative feedback effect on the secretion of growth hormone. So glucose, free fatty acids, these will decrease the growth hormone secretion. Now, cortisol. Cortisol is a stress hormone. Yes, both growth hormone and cortisol are stress hormones, but the effect of cortisol on growth hormone secretion is to reduce the growth hormone secretion. Right? Medroxyprogesterone decreases growth hormone secretion, and of course, IGF-1 and growth hormone by negative feedback will also reduce the growth hormone secretion. Now, let's look at this interesting graph which shows you the growth hormone levels during sleep. The maximum growth hormone level is close to midnight. This is the time when you see the maximum increase in growth hormone secretion, close to midnight, between 11 p.m. and 12. That, of course, as I keep insisting, that is only if you have gone to sleep between 9 and 10 p.m. If you're sleeping at 1 a.m. and 2 a.m. like all of us do, then of course this is not this timeline will not be applicable. But in normal individuals sleeping at 10 p.m., there is a very rapid rise in growth hormone in the first half of sleep, and maximum levels will be between 11 and 12 p.m. Thereafter, every time you go into the NREM stages 3 and 4, there will be further increase in growth hormone secretion. But this increase in growth hormone secretion will not be as much as you saw in the first half of sleep, that was in the between 11 and 12 midnight. But every time the individual goes into NREM stage 3 and 4, again an increase in growth hormone secretion is seen. REM sleep, growth hormone secretion will reduce. Now, this is another graph which I want you to see, and this shows you the typical variations in growth hormone secretion during the day. Now, before we see what happens to growth hormone during the day, I want you to focus on this table which is given over here. And that tells you that in the age group of 5 to 20 years, the growth hormone, the basal level of growth hormone secretion is 6 nanograms per ml. As you go into adulthood between 20 and 40 years, the growth hormone, the basal level of growth hormone secretion becomes in fact 50% of what you saw in the adolescent age group, to 3 nanograms per ml. As you grow older, between 40 and 70 years, the growth hormone level will further reduce. So that means the maximum growth hormone secretion is in the adolescent age group, 5 to 20 years age group. Now, if you look at this, now coming back to this graph, you can see over here is time on the x-axis, and growth hormone in nanograms per ml is on the y-axis. And when I'm talking about, this is the basal level of growth hormone secretion. The basal level of growth hormone secretion in this particular example is close to 3 nanograms per ml. So we can say that the individual is generally must be between 20 and 40 years. So these levels, which I'm talking about, 6 nanograms, 3 and 1.6, decreasing with age, this refers to the basal level of growth hormone secretion. During the day, there are going to be multiple stimuli which will cause an increase in growth hormone secretion. For example, let's say the first one, strenuous exercise. Sleep, maybe stages 3 and 4 of NREM sleep. Maybe there is a period of hypoglycemia here at around 4 p.m. Yes, so it's the multiple. There will be multiple stimuli during the day which will cause a sharp increase in growth hormone secretion. But the basal level of growth hormone secretion will reduce with age. This basal level of growth hormone secretion is maximum in the adolescent age group and reduces as you grow older. But like I said, during the day, there will be various stimuli which will increase the growth hormone secretion. Now, hormones in sleep, in the first half of sleep, you see a steady increase. There is an increase in growth hormone secretion, which reduces in the second half of sleep. And in the second half of sleep, in fact, it is cortisol which shows you a steady rise. Cortisol levels are maximum in the early hours of morning, generally between 6 to 8 a.m. So this is your first half of sleep, growth hormone. Second half of sleep is cortisol. Now, a little bit about the receptor. Now, as far as the growth hormone is concerned, now, right at the beginning, I told you there is no second messenger which is involved. The reason is because growth hormone acts via the JAK2 STAT pathway. JAK2 STAT pathway. What is JAK2? JAK2 is a member of the Janus family of cytoplasmic tyrosine kinase, right? And what does STAT stand for? That is your signal transducer and transcription activating activators of transcription. Yes, signal transducers and activators of transcription. So this is your JAK2 STAT pathway. Now, when I look at growth hormone receptor, you can see this growth hormone receptor. The growth hormone receptor, it has got a large extracellular portion. It has a transmembrane domain, and it also has a large cytoplasmic portion. Right? So this is your growth hormone receptor. And growth hormone has got 2 binding sites. Yes, it has got 2 binding sites. So it has got 2 domains with which it binds the growth hormone receptor. And once the growth hormone binds, it will bind. There is a dimerization of the growth hormone receptor which takes place. It becomes a homodimer. When growth hormone binds with the growth hormone receptor, it results in a dimerization. That means it forms a homodimer. There are 2 growth hormone receptors. And like I said, the moment growth hormone binds with the growth hormone receptor, the JAK2 STAT pathway is activated and ultimately results in gene expression in the nucleus. Yes, so this is as far as your growth hormone receptor is concerned. Now, the actions of growth hormone, when I look at the actions of growth hormone, there are direct actions of growth hormone and indirect actions. What are the direct actions of growth hormone? It increases the blood glucose level. It increases the blood glucose level. It will increases the blood glucose level because of it. It has an anti-insulin action. See, growth hormone is considered diabetogenic. Right? Growth hormone is diabetogenic. Isn't it? A very common problem in patients of acromegaly and gigantism is diabetes. Diabetes is generally associated is present in patients of acromegaly and gigantism. So this is because growth hormone increases blood glucose level. It has an anti-insulin action. This is diabetogenic. It increases the free fatty acid level. It is ketogenic. It increases protein synthesis. This is the anabolic action of growth hormone. It increases free fatty acid level, ketogenic. It increases protein synthesis. It is a growth hormone, so it is going to promote protein synthesis. So this is the anabolic action. It will cause a sodium, potassium, calcium, and phosphorus retention, right? Sodium, calcium. It increases the sodium, potassium, calcium, and phosphorus. It basically decreases the excretion of sodium, potassium, calcium, and phosphorus. So it causes their retention. And very importantly, it also causes epiphyseal growth. Now, what are the indirect actions? Now, indirect actions, growth hormone will act on the liver. Growth hormone acts on the liver, and liver produces IGF-1, insulin-like growth factor 1, which is also known as somatomedin C. Somatomedin C. And this question has been asked as a, this has been asked in the NEET exam. What is the source of IGF-1? The source of IGF-1 is the liver. Now, what are the indirect actions? So indirect actions will be similar to insulin. The indirect actions will be, it's IGF-1, insulin-like growth factor 1. And so the indirect actions of growth hormone will be similar to insulin. And what is that? Decreases blood glucose level. It will produce lipogenesis, protein synthesis, chondrogenesis, and epiphyseal growth. Right? So this is your these are your indirect actions because of IGF-1. Now, if you look at the direct actions and indirect actions of growth hormone, they seem to be completely opposite to each other. Right? So that means, what is the action of growth hormone? Does it increase blood glucose level or does it decrease blood glucose level? Will it increase the free fatty acid level or will it produce a lipogenesis? Now, what action of growth hormone will predominate will depend upon the stimulus. Yes. Now, if the stimulus is stress, hypoglycemia, exercise, then it is these direct actions of growth hormone which will become important. Right? Indirect actions of growth hormone, these will correlate with the basal level of growth hormone secretion. So that means these indirect actions of growth hormone will be maximum in the adolescent age group. We've already discussed that, isn't it? In the adolescent age group, growth hormone secretion is maximum. IGF-1 secretion will be maximum. So these indirect actions will correspond with the basal level of growth hormone secretion. During the day, when there are wide variations in the growth hormone, remember I showed you that graph, that during the day there are spikes of growth hormone secretion which are seen. For example, if there is hypoglycemia or if there is stress or exercise or sleep, there are increases in growth hormone. During those times, it is the direct actions of growth hormone which will be important. Indirect actions which are due to IGF-1 will correlate with the basal level of growth hormone secretion. So this is as far as your the actions of growth hormone are concerned. A little bit about the chondrogenesis. Now, remember, epiphyseal growth. This is under the control of growth hormone, right? Now, that means epiphyseal growth. That means, and out of growth hormone and IGF-1, it is IGF-1 which is more important for epiphyseal growth. And that means IGF-1, this causes the growth spurt at puberty. This causes the growth spurt at puberty. It will increase the length of long bones. It increases the length of long bones and causes a growth spurt at puberty. That I always tell you, in that age group of 12 to 14 years, all of us shot up in height. We all became half ticket, say full ticket. That is because of the IGF-1. This is responsible for the growth spurt at puberty. And please keep in mind, what causes union of cartilage, union of epiphysis with metaphysis, that is estrogen. But the epiphyseal growth is primarily a function of the IGF-1. This is responsible, like I said, for growth spurt at puberty. Dr. Achin, this is from my side, the physiology aspect. I will request you to take over and discuss acromegaly, that is.
Thank you, ma'am. Thanks a lot. One thing is very clear. At this moment, I believe the students are fasting. They are at the sleep onset and few of them are writing exercise. So that's enough a stimulus for gaining growth hormone right now. Whatever gaining is not knowledge, it's a growth hormone, pure asli wala growth hormone. But they won't gain height by the night. Doesn't mean that morning they will gain height, because IGF-1 will just stop everything.
Yes.
Right. So thanks a lot, ma'am. It was very nice session. Even I could understand a lot of physiology about growth hormone, because endocrine is 80% physiology and 20% medicine.
Absolutely, absolutely. And I'm glad we have these sessions together. Then we can put across our points of view much better to our students.
Bilkul, ma'am. Anytime. Because if they understand the basic physiology part, medicine is always a cakewalk, I believe. It's not a tough task.
That is true.
So good night to you, ma'am. I'll continue the session, and good night not to the students. I'm still there for you.
Yes.
So, thank you. Now let's discuss what happens to a patient with acromegaly. What are the symptoms that we often see in patients of acromegaly, right? So in an acromegalic patient, as I come across with, there are some changes. There's some changes that we find in the phenotype. The phenotypic changes are the most important that we often identify the patient with, in which the frontal bone becomes more prominent. It's known as frontal bossing, as you know. Then the brain may also show some mental disturbance, insomnia. Face has got coarse features like prognathism, jaw malocclusion, in which the jaw increases in height and the lower incisors space off from one another. So they're occluded in a normal person. So there's a gap coming between the lower incisors in them. The eyes also show me a glaucoma and hemianopia, okay, as a problem. Heart also shows a lot of soft tissue changes like left ventricular hypertrophy and coronary artery disease finally. Hypertension is also there. Organomegaly is there, especially the liver and the spleen happen to increase in size. Large digits are there, that's why the name is acromegaly given to it. Osteoarthritis again is another problem with them due to increase in the epiphyseal end. Skin is showing hyperhidrosis and temperature intolerance anytime. And large feet, of course. So they got a big feet also. Now, we should realize this fact that diabetes is another killer problem in them for any time. Because as ma'am suggested, that growth hormone will rise in hyperglycemic situation, but if it is in excess, it will cause some kind of an insulin resistance, decrease the insulin secretion and all, and result in hyperglycemia finally. But remember this, they got an indolent course for almost 10 years time. That means for 10 years they remain undiagnosed. So all these symptoms, they're very subtle kind of things in them, which often get undetected for around or undiagnosed for at least 10 years time. Acute MI, if you remember, happens to be the cause of death in these patients, right? Don't forget that. Etiology of acromegaly, if I list, it can be due to excess of growth hormone in the patient, which can happen due to a pituitary cause, or can be from other part of the body like ectopic cause. So not from the pituitary somewhere else, it's an ectopic cause there. When I look at the pituitary cause, I have the most important cause over here. That's a somatotrophic adenoma. Now the pituitary adenoma is not a prolactinoma anymore. It's sitting in the somatotroph cells. So it's a kind of a somatotrophic adenoma, right? Mixed growth hormone and prolactin adenoma. What does this mean? So that's the pituitary adenoma, that is prolactinoma and somatotrophic both together over there. So some of the cells are secreting this, some of the cells are secreting that. That's 25%. And then we have a mammosomatotrophic adenoma. So there's an adenoma which secretes both of them simultaneously. So it's a mixed bag in a mammosomatotrophic adenoma. But for you at your end, you should only remember one etiology, that's a pituitary, most important cause that you know as a somatotrophic adenoma, seen in around 60% of the patients. Ectopic, if I look around, we have got the pancreatic isolated cell carcinoma there. And the second cause that we find is a lymphoma, right? Second reason that we find directly with this is increase in the GHRH production. Growth hormone releasing hormone is basically produced from the hypothalamus, and there's a problem which is a laughing epilepsy known as the gymnastic epilepsy or a hypothalamic hematoma as a cause for excess of GHRH and finally excess of growth hormone. Ectopic cause is also there. There are a lot of malignancies. Again, I'll not tell everyone, but we suggest a bronchial carcinoid happens to be a very common thing nowadays. And most of the patients, if bronchial carcinoid, if they've got acromegaly, the symptoms of acromegaly are not that evident as compared to any other cause. Now, one thing we realize, as ma'am said, that there's a kind of a negative feedback. The growth hormone rises, the IGF-1 rises, and that will push down the growth hormone level. So that's a blessing in disguise we all have got, right? But in patients of somatotrophic adenoma, that doesn't happen. So he doesn't listen to IGF-1 at all. So that's a very clear thing. So there's a loss of negative feedback. So the growth hormone works, the IGF-1 works, so 1 and 1 together become 11 for the patient. And the person may not gain height after the epiphyseal fusion like in acromegaly, but obviously they will have large jaw, large digits, and every problem there. Most common cause of acromegaly, remember, it's somatotrophic adenoma. Workup is very simple. We are going to go for a screening test. Going and doing a serum IGF-1 level will make us more wiser on this because growth hormone rises physiologically in pregnancy, physiologically in our daily life. So it's very difficult to say that it's a growth hormone which is a physiological or a pathological rise. Secondly, the growth hormone also has got a very short T-half. So that's another problem that we face with the growth hormone level assay. So we'll go for the IGF-1. If that's high, that's the main troubleshooter over here. Then the next test that will come is a confirmatory test that will do a growth hormone suppression test. I've discussed this in the class also. We give 75 grams of oral glucose to the patient. We try to suppress the growth hormone level. Naturally, that will happen. But here it will not happen because that negative feedback story is not there. And most important, remember, whenever the glucose goes down, the growth hormone rises up. So you basically increase the glucose and you try to suppress the growth hormone. But in somatotrophic adenoma, there is a tumor producing so much of growth hormone there that won't be possible. So the test that is confirmatory is always a growth hormone suppression test for them. Then we look for the cause, etiology. For this, MRI pituitary is the right thing. And we are going to diagnose a pituitary adenoma or a somatotrophic adenoma there. We already know the most common cause. Management of acromegaly is a very simple flow chart. We've discussed this in the class, DBT every time. That management, the treatment of choice is to remove the tumor as fast as possible. The transsphenoidal resection is very clear. Then goals for seeing the patient better or not is to check the growth hormone level. On the post-op day 1, has it come normal or not? IGF-1 level, has it come normal at 12 weeks or not? MRI repeat at around 12 weeks time. Right? So these are the goals that I look for. Now, reassess the patient. If there's a remission and we have reached the goal, then in that case, we need to just go and do the annual growth IGF-1 or a growth hormone suppression test. If some problem occurs, then accordingly we take the treatment. Otherwise, just wait and watch. And get an MRI done if there is some sign and symptom which is suggestive of the relapse of the disease, right? If incomplete remission is there, we go for the medications. As ma'am suggested, one of the very important inhibitor for the growth hormone production is a somatostatin. Statin means stopping the somatotroph cell. And we have two brothers lined up over here, the octreotide and the longer brother, lanreotide. And then we have a growth hormone antagonist that we don't rely that much on, is a pegosamab. For an MCQ purpose, remember one thing, the first treatment is always a surgery. If there is an incomplete remission, then you go for a medical line of treatment. So it's always a kind of an adjuvant therapy, add-on therapy, right? And out of the two, remember this, pegosamab versus somatostatin analog. Somatostatin analog are always more preferred over here. They're always more preferred as a treatment for these patients, okay? So we can start with an octreotide therapy and see the patient. If there is no relief, then we may go for a pegosamab, okay? But there's a patient with me whom I found that in spite of medical therapy, I'll just switch off my camera now. There was no response. In that patient, I will go for shrinking the tumor by giving what? A radiotherapy. That will be the ideal for this patient. Special consideration, remember this, if a patient's tumor is unresectable, it's a very big tumor, it's not resectable, or it's a poor surgical candidate. He has progressed so much in his systemic problems with acromegaly, so many disorders were there that you cannot really operate on him. Then in that case, we start with the medical line of therapy first, and most of the time, if there is no relief for the medical line of therapy, then we can go for the radiotherapy as well. Okay, so at the end of the day, we might have to give them radiotherapy. We should realize this in people whose tumor is surgically unresectable and who are a poor surgical candidate. So what is the take-home message over here? Growth hormone is a good hormone until it's been inhibited by IGF-1. To diagnose an acromegalic patient, don't get the growth hormone level down, because it might rise physiologically so much in a day, short half-life, so go with the IGF-1. The confirmatory is a growth hormone suppression test, and the etiological test is to get the MRI brain done. Look for the remission after surgery. No remission, then proceed for the medical line of therapy. Okay. Remember this, as we discussed prolactinoma, all is well. Growth hormone, all is not well. Usually patients of acromegaly die 10 years earlier than their own counterparts of the same age due to CAD and acute MI. So time is very important thing over here. To operate them on time is the most important thing, right? So chalo, we're done with this simple topic. I'm not going to stretch it too much. This much piece of information is more than sufficient for you guys, right? Growth hormone receptor activates the GS, must be internalized to exert its effect, resembles the ACTH receptor, or requires a dimerization for its effect. Now answer my question, please. Ma'am has already discussed this pathway, and she has shown very well in her diagram what happens over there. If you're attentive, you could have known the answer there. Waiting for your answers. Good. Mugambo बहुत खुश हुआ. Okay, you're not a kacha badam, you're not peanuts. Okay. Chalo. So answer is B or option 2 on 2, 2, 2, 2, 2, 2. Right. Okay. Which of the following symptom is more common in individuals with acromegaly? Prognathism, khali jaw, or sex steroid deficiency, visual field effect, or hyperprolactinemia? Let's see. I did not tell this. Let's see how many of you answered it correctly. I'll be very happy. Don't Google it. You won't find it. Prognathism fall more commonly. Oh my God. Hyperprolactinemia is seen. Achha, matlab jo, the piece of information that you have in your mind, you'll put it as the best answer. Half knowledge is always dangerous. So no knowledge, no tension. There's one student who will leave this question here. My dear friend, the answer is not D, prognathism. No. See, I'll tell you the story here. Somatotrophic adenoma, why were we so interested in operating upon such people? Why were we such in a hurry to operate upon them? It's not due to the tumor producing so much of growth hormone and causing all this problem, right? It was just because most of the time, look at this contrast. Prolactinoma and a somatotrophic adenoma, the two tumors which can come in the pituitary, right? Anterior, right? Prolactinoma, as I said, 90% were micro. But wait a minute, somatotrophic adenoma, most of them are macroadenomas. Macroadenomas, please remember. And one of the more common symptoms that they come is compressive symptom because of the tumor. Like headache is one of the symptoms that is found in these patients of acromegaly. Correct? Second symptom due to compression is a visual field effect. Bitemporal emmenopia. It's more common than prognathism. See, I'll tell you the story here. The growth hormone may be produced slowly, but that phenotypic appearance will take time to happen. That's why it's known as an indolent disease for 10 years, because that phenotype comes quite late, 10 years later, right? Then you really realize when you break your head, oh my God, we were seeing it as a case of acromegaly. All this time, patient will have headache, visual problems and all that. That's fairly more common than prognathism. I'll be very happy with any one of you if you can tell me this answer. Some of the neuro lectures I've discussed this. What is the cause of headache in acromegaly patients? My question for you guys, what is the cause of headache in an acromegalic patient? Is it the tumor or is it the CSF? That's the head. If you can tell me the disease entity, I'll be very happy. The cause of headache in acromegalic patients. Anji. Glaucoma. Oh ma. Yo. Glaucoma is the cause of headache. Raised ICP. Quite near to that. Can you tell me the disease entity? Raised ICT, CSF. Tell me the picture ka naam na. That's pseudotumor cerebri. Many of the neuro lectures have described this concept. In acromegalic, as the name suggests, that there is hyperplasia everywhere. The person bone grows, the body grows, and the person grows like a khali. So there is a proliferation in the choroid plexus also a lot in them. That increases the CSF secretion and raised ICT without hydrocephalus, of course. That's the pseudotumor cerebri. Not the increase in the head size causing raised size. No. It's actually pseudotumor cerebri which is seen as a cause for headache in these patients. Now, why I'm talking about headache so prominently over here? Because it has been a study in our country, in Vellore itself. There was a trial done that we found that every acromegalic who came to our OPD initiated the story with headache. Most common symptom maybe, if you can look upon in a patient of acromegalic, is headache. Like prolactinoma, it was infertility, correct? With galactoria amenorrhea syndrome. Acromegalic on the other end will always have headache as a very, very prominent symptom in them. Don't neglect it. Phenotypic things take time to happen. It doesn't come in a week time. Like I've got a somatotrophic adenoma, next week I'll have no. That won't happen that easily. Okay. So the answer that you found thought to be half knowledge prognathism is not the correct answer. The answer is visual field defect. Okay. Right. Now, Bula. Which of the following is accurate about epidemiology of acromegaly? Gigantism is more common than acromegaly. Gigantism, I believe you understand this before the epiphyseal fusion. Acromegaly is typically associated with delay in diagnosis. Mean age of onset of acromegaly is second decade. Men develop acromegaly more frequently than the women. Sang mala jo mala mahitte nahi. Tell me something which I don't know. ये तो ठीक था. 2. Option 2 or B. Okay. Even if I have not given option 2, then you would have been in trouble. Chalo, मान लो there was no option 2 given. फंस सकते थे. You could have got caught somewhere there. Chalo. Acromegaly is anytime more common than gigantism. Don't take Khali as an example and think he's gigantism, so that's more common. No, acromegaly is, more common than gigantism anytime. There is a delay in diagnosis indolent course of 10 years time. Mean age of onset is not second year. It comes in some 30s and 40s usually. Yes. And men develop acromegaly more frequently than women, or women develop more frequently than men. Can you correct me on option B? Who has it more commonly? Acromegaly. Male or female? Who has it more common? For this, I have already answered your question. Who has it more frequently? Male or female? Sang mala. Jo mala mahitte nahi. Bolo. Tell me something which I don't know. Answer for this question. Yeah, equal, Chaitanya. Very nice. Equal. Why? Somatotrophic adenomas are macrodenomas most of the time. They are equally common in males and females. Nothing like female will have this. No. Okay? Equal. Not men. Men develop more frequently than women. Then D would have been accurate answer. Then why did you give me B as an answer? You could have gone and marked it as D. No one of you gave me D as an answer. equal in men and women, right? Chalo. Any doubts, any queries on acro or prolactinoma? Let me know. Kacha badam. Some of you are waki mein kacha badam in the batch. You require some polishing. Remix is required in your life, right? So some questions are not peanuts, right? बताओ. Any doubts? Hello. Then very good night to all of you, and you have been a wonderful audience as usual. And no one asked today that how many pages class will end at what time.